and welcome. I'd just like to begin by making acknowledgement of country. Today we stand in footsteps millennia old. May we acknowledge the traditional owners whose cultures and customs have nurtured and continue to nurture this land since men and women awoke from the great dream. We honour the presence of these ancestors who reside in the imagination of this land and whose irrepressible spirituality flows through all creation. I'd also like to acknowledge the traditional custodians of the various lands in which you work and live today, and any First Nations peoples participating in Go Rural virtually. I pay my respects to elders past, present, and emerging, and celebrate the diversity of First Nations peoples and their ongoing connections and cultures to the lands and waters of Australia. So, as I said, my name is Meredith. I welcome you on behalf of Health Workforce Queensland, and I'd like to welcome you to Go Rural Virtually's Where's the Harm? Healthcare in Correctional Facilities. Tonight, we're going to be escorted behind the walls and razor wire that characterise prisons to explore how clinical care is delivered and experienced on the inside. While our criminal justice system is not on trial here, we acknowledge the ongoing challenges and impact for those who live and work in correctional settings. To set the scene, we'll begin by identifying the two key service organisations who manage Queensland prison population. The first being Queensland Corrective Services. They're responsible for the containment, supervision and rehabilitation of over 11,000 prisoners who are accommodated across 12 high security and 7 low security correctional facilities. Queensland Health is responsible for providing prisoner health services. These services include primary health care, specialist outpatient, mental health, oral health, and inpatient services. These health services are delivered by 8 hospital and health services. To help us understand what correctional health care looks like in real life, we're joined by 2 doctors and the nurse unit manager who work at Lotus Glen Correctional Centre in Far North Queensland. We also have the nurse unit manager from the PA Hospital secure unit based here in Brisbane. And very importantly, we're joined by 2 former prisoners who were incarcerated in a variety of correctional facilities, plus the parent of a prisoner. So to start our discussion, I'd like to welcome Dr. Lewis Peachy. Lewis, can you introduce yourself and describe your role at Lotus Glen, please?
So my name's Lewis Peachy. I'm a Gidimay and Jilbal man from the Jilbal language group of North Queensland. We are the rainforest people of far North Queensland on the Cairns hinterland. Gidimay are the people between Lucinda and Rockingham Bay, so where Tully Heads comes out, and we go up onto the Atherton Tablelands and include the areas around Ravenshoe, Herbert and Mount Garnet. I work at Lotus Glen Correctional Centre as a senior medical officer. My main role is actually in the prison farm, so there's 2 main sections. The larger population is in the high security unit, which houses between 15 and 2,000 people, depending on how crowded things are. Over at the farm, it can be between 100 and 200 people. It is actually a working farm, and we've got cattle, we've got bananas, we've got other orchard crops that are all there, and the men who go there do go there to literally to work, and you have to be able to work and able-bodied to work in order to stay there. Yes, prisons is an interesting place and a very interesting place to visit. Especially for me as an Aboriginal man, walking into a prison as a medical officer is incredibly surreal. An awful lot of my family members have gone inside who don't have anything like the privilege that I have when I walk inside. I walk inside knowing that I'm coming out later on that day. You know, a lot of my uncles and cousins who've been in there, they were never sure when they were coming out. I think as you walk into the prisons, look, the farm unit is it's very low security and it's very easy going. When you do go to the big house, that's when that's very confronting and very shocking. So there are multiple scans to go in, where you get scanned to make sure that you're not carrying anything with you. Anything that you do take in goes through a scanner, a bit like going through the airline security, only a bit worse. And then as you walk in through the different sections of the prison, you are confronted by the multiple airlocks, and so you walk in through one incredibly heavy metal door, which will then slam shut behind you with an extreme metallic clang, and then you wait in the middle of this no man's land, waiting for the eye in the sky to spot you and allow the next door to open, and then the next door opens, and then you go to the next section, and you repeat this over and over again. And as you go deeper and deeper inside the prison, you can feel your autonomy wane away from you. And even if you're a privileged medical officer, getting into and out of, you're counting on other people watching you. You're counting on other people looking after you. That you're no longer genuinely in control of your own safety and your own autonomy. That you're fully reliant on the corrections officers who are giving you safe passage in and out of the facility.
Thanks for that overview, Lewis. According to the Queensland Corrective Services website, Lotus Glen aims to build cultural safety into its programs and services, as approximately 70% of the prisoner population are Aboriginal and or Torres Strait Islander. From your perspective, what considerations should be made when it comes to healthcare for Aboriginal and or Torres Strait Islanders?
Look, I think the thing is that the group of men who we look after, these are the men who are probably the most damaged from our communities. These are the men who are so some people use a term of disenfranchised. I would actually correct that term to be unenfranchised. These are not people who had the franchise and lost it one damp Sunday afternoon down the back of the piano. These are people who just never had the franchise. These are people who for whom society never properly worked. Particularly a lot of the Aboriginal men in there, they know that they were excluded from the Great Australian Dream like everyone else, and that they've probably known that from about somewhere between 7 and 9 years of age. That it became apparent to them that all those things that were available to other people weren't available to them. I think the frightening thing at times, though, is when you talk to the non-Indigenous prisoners, is you'll find that experience isn't just for the Indigenous inmates. That for a lot of the non-Indigenous inmates, that their world of limited control over their circumstances, limited control over their future, that for all the benefits of being white, for these guys, there's very little there, and that the environment that they are in, they may as well grown up in the worst of the missions, because it certainly gave them no advantage when they find themselves inside. So it's and I think that's a thing that's so poorly understood, is a lot of these guys that they're broken. They're very badly broken. And I know that we'll get into the issues of mental health later on in this, but there's a massive mental health burden. There's a massive burden of neurodiversity, massive burden of fetal alcohol syndrome. There's a massive burden of physical deafness. So estimated between 80 and 90% of the Indigenous inmates have significant hearing deficits. and their the options that most citizens of Australia have in terms of their freedom and their future and their autonomy and self-control are just cut off for a lot of these folk who find themselves in prison.
Yeah, well, it's doubly exacerbated because it was already like that before they were incarcerated.
Yeah.
Yeah. Thank you for introducing us into Lotus Glen, Lewis. As part of tonight's discussion, the Health Workforce Queensland team have some challenging questions to ask our speakers. These questions are designed to confront the preconceived ideas often held about imprisonment and prisoners. Evelyn, we'll get you to ask the first question, please.
Yes, thanks, Meredith. The first question is, don't people go to prison just so they can get 3 meals a day and a roof over their head?
Well, I think, okay, there is actually a small factor of truth to that. But the horror is not understanding what's behind the question. When somebody, and there are, look, there are boys that I look after that is exactly true, but their life outside is so horrid, is so devoid of self-control, is so, you know, is so predetermined by factors outside of themselves that actually it does turn out that being stuck in a damn cage and getting fed 3 meals a day is sadly a better option than what it is that they face. But I think that's a terrible reflection on us as a country. One of the richest countries on God's green, lovely earth, and yet we have people who are citizens of our nation who are finding that being locked up in a cage and being fed 3 times a day a preferable option to what's available for them on the outside. So there's some truth to that, but not actually in the way as it's often. It's no holiday in prison. It is no nice place to be. It's a really, really horrible place to go. And for some people, that horrible place that has 3 meals a day is the least bad place that they can be. And that should make the rest of us feel horrid.
And I think for many women, it's a place of safety from abusive partners and families, and it's
Yes.
a place of safety. Yes.
And again, isn't that awful that woman has to go inside a cage to feel safe inside her own skin? I think that's a societal wickedness that woman finds herself in that circumstance.
Is anybody else would like to respond to that question?
I'm just going to interrupt you for a second about the place of safety that prison is, because today I struggled to do my clinic because of Code Brown. So Code Brown is a hostage situation. So the person had taken their cellmate hostage. So I would argue that suggesting that being locked up in prison is a better place and a safer place is being put by children in corrections who might state that they are beaten and raped less in prison.
Yes.
So that's our society that we live in.
Yes. Yes.
Thanks for sharing that, Emma. That would have been very confronting.
Could I ask you a quick question?
Yes.
Lewis, I'm just curious about how you were saying that 80 to 90% of the incarcerated population are deaf. Is that like a health issue that's not being managed in the prisons?
Yes. So sorry, just correction. 80 to 90% of the Indigenous population. Just for those numbers largely come from 2 authorities. One being Kelvin Kong, who's the first Indigenous ENT surgeon, well, the first Indigenous surgeon in the country, but certainly the first Indigenous ENT surgeon, and Sam Harkis, who's a fairly renowned audiologist, who's an authority on it. And yes, by and large, it's to do with untreated community burden. there was at 2017 Rural Wonka held in Cairns. There was before the day proper before the conference started, were a number of excursions that were available. One of these excursions was a bus trip over to Yarrabah. A number of delegates got on a bus and they went over to Yarrabah. Mostly they had just had a good day learning how to throw boomerangs and spears and eaten some pretty flash bush tucker. Just before they were about to get on the bus, about 10, 15 minutes before they were due to be herded back on the bus to go back to the hotel, one of the health workers got them into a room and put a small, a very brief PowerPoint slide presentation up on the screen. And so they introduced herself, and then the next slide over says something to the effect of 50% of the school-age children in this community suffer from chronic security of otitis media. Next slide. Next slide says the average wait time for a child in this community to see an ear, nose, throat surgeon is 5 years. That of course prompted the group full of doctors. Nerds are easy targets with getting them to Dorothy Dixia, and so one of the guys put their hand up and said, "So, are you telling us that for half of the children in this community, for half of their school life, they cannot actually hear the teacher?" To which the health worker said, "Yes." And it's that bad. Now, of course, when you look at the guys who are ending up in prison, they're at the worst end of it. So just as there's a name of I think it's a Justice Health Group, which includes a number of people from various universities. I know, including Edith Cowan and Harvard and a few of the other folks around the sticks. There were some publications that they've come out with. Essentially, they've demonstrated that if you are a child and you are in police custody, so before you've gone inside, before anything has actually happened to you inside a cage, the fact that you're a child and in police custody, you are now 4 times more likely to die than anybody else your age. That the people who end up in incarceration are people who have already been failed by the health system demonstrably. And the high level of deafness, mostly due to chronic secretive otitis media in one form or another, is just further demonstration of the failure of the health system to engage that group of people. And that's, that's part of the challenge of healthcare in the prison. These are folks who don't have a good history of having, lovely, beautiful interactions with the health staff. It's a new experience for them if they're able to enjoy a consultation.
So I think we'll take this opportunity just to shift our focus to the nursing. With just over 2,500 nurses working in correctional settings nationally, compared to the 44,000 working in residential healthcare, it would be easy to assume that correctional service isn't a popular career choice. That said, one of the defining characteristics of correctional healthcare is that it's nurse-led. This would suggest nurses have opportunities to advance their careers and take up leadership roles. Jo, you're the nurse unit manager at Lotus Glen, where you've worked for 8 years. What path did your career take to get you where you are today?
So I've been nursing over 20 years, and during that time I've worked in real remote areas, in an accident and emergency, as well as surgical and medical wards. It also included working for Defence as well. However, I had been 8 years as a correctional nurse, then went back to Queensland Health, and has since returned back to corrections as a Queensland Health employee. Started as a clinical nurse on the floor, and in the past 4 years have been the nurse unit manager at Lotus Glen. So that's a bit about my history. Now, working within the correction centre, it's a very broad experience, as it's not just one field. It has multiple facets, such as accident and emergency, chronic disease, mental health, opiate dependent treatment programs. So it's sort of a community within a community, and trying to get the best to our inmates. And during the structure of corrections, it can be limited.
How many staff would you have working in the unit, Jo?
There would be about, including our casuals and our admin, pharmacy, as well as doctors, there would be about 50 of us within Lotus Glen. So on an average day, there is about 8 medical staff as nurses. On the medical side, there's about 3 to 4 nurses on the opiate dependent treatment program, but that doesn't include your admin or your pharmacy as well. We do also have like nurse practitioners, and they're 7 days a week. And as you said before, we are a nurse-led practice. We do have 2 medical officers and 1 who is only a 0.2 at the moment as our opiate dependent treatment program. So, and hopefully, yeah.
So what does a typical day look like, if there is such a thing as a typical day for the unit, Jo?
Okay, so working on the floor, you have about, our shifts are 12 hours. So you're looking at 6 till 6 or 6:30 till 6:30. And the night shift is from about 6:15 p.m. to 16:15 in the morning. So on a typical day, if you start at 6 o'clock, you're preparing medications for about 2 hours. You have to be ready by 8 o'clock to go to the units where you are allocated, and you will be there for about 1 hour and a half to 2 hours to administer. You will come back to the unit, to the medical centre, and then you prepare for like an outpatient clinic. We do have doctors there Monday to Friday, but like I said before, we do have nurse practitioners Monday to Sunday. So, you know, they've got their clinics, and we do provide other services such as a physio once a week. An optometrist comes there every 6 weeks who has newly come. You have dental clinic about 5 days a fortnight. So, and you've got mental health there Monday, Tuesdays, Thursdays and Fridays. So depending on the clinic will depend on how many prisoners you can get to see in one day. And that doesn't include whether there's lockdowns. And as Dr. Emma said earlier, code brown. We do have a code silver sometimes where they're on the roof. So, but most days you will get code blues. So they're your medical emergency responses. So besides doing your clinics, you've got to respond to these codes as well. And it can range from kicking his toe, toothache, or a cardiac arrest. So you've got a trolley with your pack, and it can go from like a football field to an actual cell. Then in between all that, you can have your morning tea, lunch, afternoon tea, but then you've got another 2 hours to prepare for your evening medications and have to leave the unit to go to your designated area at 4 o'clock. And this is maybe where we do poorly, because at 4 o'clock, people are getting their sleepers, which keeps them up half the night, which they think, process a lot of stuff, and then call a couple of more codes during the night. So that's your typical day, and then you go home. And you haven't done half of your work.
Yeah.
But it can be challenging, but it's also enjoyable, because when you do have that interaction with the inmates, they are people. They've got stories. They have a life. just like anyone else.
So it sounds like it's structured, but it's also, you have to be ready at any given point to respond to the unexpected.
And
So-
Dr. Emma could probably speak more about the opiate dependent treatment program and how they operate over there.
Yeah,
But, yeah.
we're going to certainly talk about that in depth.
Excuse me, Meredith, there's a question in the chat. It says, when you say prep meds for administration, what do you mean?
Okay, that's when we, the system that we use are pre-packed medications that are done by third parties. So you're checking the medication against a medication chart to make sure that what's in that pack is what's actually being prescribed. And if it's not, you have to get the medication to have for that inmate. So you could have like between 80 to about 100 packs that you've got to check before going over. Does that answer your question?
So you actually have quite a number of pharmacists on site working in the unit. And Lewis, are you responsible for writing the scripts?
Yes, so we've got medication charts that we write up, and the different sections of the medication chart for the regular medications, the as required medications, the short order medications, and then the stat administrations. So on a reasonably complex sort of a medication chart, which then lasts for usually a couple of months worth of dispensings before it needs to be rewritten. And so yeah, we do write those up. So the nurses also arrange for us to go through and review them from time to time to double check to see who should still be on what medications. And just watching medications and making sure that things are safe there is a pretty heavy task for the nursing and pharmacy staff to do, to double check what it is that we're doing and making sure that everybody's getting what they need.
So I'd like to turn now to clinical care from a prisoner perspective. Wayne, you've spent time in a correctional facility. What's the process if you require paracetamol in prison?
So depending on the nurse on duty, you can go down when morning meds are taken to get your scripted medication and ask for paracetamol. If you get, a couple of the nurses didn't offer any medication because it always had to be scripted, they said. So if you had, I mean, I've got mine, this is what I used to have, that's mine. I had an allergy to the sheets, the washing powder. So I had hives every time when we did our sheets, our beds, I'd get hives. So it took me, I got loratadine prescribed for the month. I only needed it once a week, but the nurse wouldn't give me any histamine on that day until I got it scripted. So then I had to fill in a medical request form for the script and then wait for 3 days. Then they gave me a daily med for the month before I got out. Yeah. So if you got a good nurse, you were able to get antihistamine, but a couple of the nurses you just didn't bother going up. Unfortunately, it's, there might be the hard rule where I know they had the little packs and sometimes they'd run out. So you wouldn't see them until the afternoon, and then the nurse in the morning was the most important person to see because that's when you give your medical form in if you needed any medical requests. So when I was taken into custody, I was on antidepressants and anxiety medication. I managed to get a doctor's appointment confirmed on my medical request form a month after I was incarcerated. And I had on bail a month later without any medication for my mental health. So it can be a bit hit and miss. But, you know, as I said, it depends on what constraints the medical staff have and what's going on, what they can carry in the system inside the facility. My intake nurse was probably, you know, my closest friend in there when I first went in, because I mean, I'm 54. I've never been incarcerated before in my life, never been in trouble with the law. It was for recreational drugs. She looked at my chart when I was going on intake and she said, look, do not accept anything from anyone in here. They'll find your house. You'll walk out of here with Hep C, HIV if you haven't got it already. She said, you're a nice man, like, just stay clear. And talking about, when we're talking Lewis, the young Indigenous people, very impressionable and they like to get in with the brothers. And one guy, he'd never used IV medication, IV drug use before. Within 24 hours of being inside, he had a subby injection and was in his cell for 3 days sick. And yeah, it cost him his buy-up and his meals for the week. It's just very sad, you know, what you see on the other side of it. I mean, you're talking about, sorry, Joe, you're saying that the nurses come down at night if there's any emergencies. Where there's a code amongst the prisoners, you don't push that call button. You do not push that call button. You could be dying. You don't push it. And well, I've got a great respect. My partner's a doctor. And, you know, I understand there's constraints with nurses, what they can prescribe and things like that. It was very frustrating. And, you know, some of the things that I saw in there would certainly make your toes curl. You know, when you're in a lockdown, you can get out in the morning to your meds. So over Easter, you know, we're all in lockdown. And I went down just to get out, just to get some Panadol. You know, some of the guys had the Panadol prescribed for them so they could go down every day, and they'd have a storage of Panadol. But, you know, if you did have a headache or anything, you'd try and sneak one or two because you weren't sure who was going to be on the day you had a headache. So you sort of kept them. But I heard the other day you could get them through buy-up now, which is great.
Yeah, it's just a recent change. It's quite phenomenal given, you know, how difficult it was to get previously. Joe, can you take us through what happens when there's a code blue, in other words, a medical emergency in Lotus, in Lotus Glen?
Okay, so an officer will actually call the code blue. So what happens is two nurses and a medical officer will go down to where the code is, and the trolley with the resus trolley goes down with it, depending in which unit. The nurses will do their first initial assessment, and depending on that assessment, will determine whether they have to go up to the medical centre. And from there, they will be further assessed. And because we've got doctors there now Monday to Friday and a nurse practitioner again Monday to Sunday, they will determine whether that person needs to go to, you know, the hospital as well. So depending on what it is.
So I just at this point I want to bring in Sarouj. Sarouj is the nurse unit manager from the secure unit at the Princess Alexandra Hospital here in Brisbane. Sarouj, what's the purpose of the secure unit?
Hi everyone. So secure unit was established in mid-90s when most of the prisoners were located within Brisbane area. So the large population were in Brisbane. Secure unit is on site of PA Hospital. So PA Hospital is a tertiary hospital with all services, so all specialties. The unit itself is very small. It's only got capacity for 12 inpatients. Outpatient is quite large, so we look after about 30 plus specialties over 5 days. We've got a dialysis service as well running through here. We used to see our own ED patients. That's been discontinued due to we not being able to accommodate that in our unit. So how do you enter a security unit? Inpatients, you can come through emergency, you can come through outpatients services, or you come through inter-hospital transfer. We try to not take too many inter-hospital transfers because we don't have the capacity, unless it's urgently needed, because the service is only available in PA is why you would be transferred, or there's a request from corrections because the person is a high profile person, then they would be accepted from outside the area. Occasionally, the local services are very reluctant to have these patients there because they come with officers, so they're worried about the general public's exposure. We take that into consideration as well, but to balance that, the families are, so there's a patient here in PA at the moment from up north, which I don't consider very appropriate because he's got all his support systems in that area. So we try to not encourage inter-hospital transfers. The outpatients generally comes from referrals from all over Queensland. So we are the only facility in Queensland that can provide some of the services. We do encourage patients to be referred to local hospitals, but same thing, local hospitals are not set up to have these patients in general public areas, waiting areas. So that would be one of the reasons that most of our outpatients come to PA hospital. So they come through referrals through ED or referrals directly from offender health. We maintain a wait list that is measurable against Queensland Health's wait times. So prior to, we used to have a lot of restrictions on where we could keep records of these patients, but that has all changed since we went into IMR. Our patients are very much visible to all the auditors within Queensland Health. So we do provide service equal to the general public. The unit itself is staffed by QCS staff. So the entry is exactly like Louise described before into a prison. So we follow all those restrictions for entry. Everyone coming into the unit would have to follow what QCS applies to the entry. Exception is when we have a code, there is a different route to get into the unit, considering that this is an acute care area, so the codes are actually medical codes. Within the unit, we have many correctional officers, so the inpatients have different correctional officers, and outpatients has a different number of correctional officers depending on the day of the clinic. So the clinics are very large. We'll have quite a few correctional officers. The nursing staff are employed by PA hospital, so we come under PA. We are not offender health. We have a pharmacist full-time. All our allied health services are external, so needs to basis. We will get them into the unit if we need them. We do have rehab and palliative patients as well. For the rehab patients, they do not have their full rehab within the unit. They go and attend rehab outside of the unit, but they will be staying overnight here. Similar reason, rehab units are not, not built to have patients with escorts around them. So we do have to have them here. Palliative patients, on the other hand, if they don't have outside support, we would keep them here, which means if they don't have any families that would be able to support them till they're very unwell, we would move them to the main hospital, which is a bit different, or the palliative care unit for the end. If they have families, we very much get involved and get them out of the prison situation so that they can have families around them in their last moments. Some of these things take a long time. We would want them to be quicker, but working within prison, I've learned that patience is what you need and persistence. So those are the services we provide mainly. So we have barriers to discharge quite a bit, because prisons not all prisons are 24 hours staffed with nursing staff. So some of the patients who need very little care or help cannot be discharged. So we often have stranded patients, which puts a lot of pressure on our beds. So on any given day, the main hospital would also have about anywhere between 5 to 15 patients just needing a bed. You know, they are exposed to the public areas, which sometimes is not very good for them as well. It's they are restrained where within the unit they're just behind a locked door, whereas if they're out in the public wards, they are actually restrained to the beds. So often I would have to go out to the wards to talk to the staff about how to manage that. Considering the safety of you know, everybody around them as well. It's just not a nice place to be. Yeah. However, beds is a difficult situation for everybody here and everywhere else. So
I think when we were speaking and when we were preparing for tonight, Suruj, we were talking about you're not able to use crutches in the unit. And I think for the allied health students, it would be interesting, well, for all the students, it would be interesting to know, you know, why that is and how inventive you have to be.
Yeah, so within the unit, we use crutches, but if we were planning discharge, we have to negotiate with the prisons to see if they would allow this particular person to be able to use any appliance, so crutches or wheelchair or whatever that may be, or just a moon boot even. So the prison, the corrective services have a lot of say. So I've got a guy here today and I want to discharge him with moon boots because he's got some historical you know, issues with self-harm. They wouldn't allow him to have a moon boot. Now, you really can't discharge a patient who needs a moon boot to a prison, which will not allow him to have a moon boot. So that's, you know, those kind of things. And it would be the same with crutches, because corrections will risk assess him or whoever that patient might be to be using his crutches against someone, or someone using the crutches against him. And prisons are not really built to cater for any kind of disability. I think you know, they have long distances to travel to go and get their meals and all sorts of things. It's not really a place where you can walk around freely with your crutches.
Exactly. We're going to turn to Wendy now, who has a question for you, Suruj.
Yeah.
Aren't you scared to work with aggressive prisoners?
With no, no. Aggression comes because there's a need for something that is not met. I have learned listening helps. I met someone just recently, someone who came to visit the unit, and they mentioned that they're surprised how quiet the unit was with the staff. So there is aggression, and aggression is not only within this unit. There's aggression in other units as well. I worked in various places before I came to this unit. Honestly, I find aggression happens when there's some needs not met. The answer to that is you listen and you figure out what is missing in this whole conversation where aggression has developed. So yeah, we do train our staff exclusively about this de-escalation. So we give a lot of training to our staff about de-escalation. So when there's aggression, you don't, you know, raise your voice to listen to, have a conversation. You just need time out. I've learned time out is a good thing.
We've got some questions from the audience. Alex has asked, I can imagine there would be a lot of times where nurses may feel quite limited in the help they can provide to patients. How do you get past feeling like you're letting people down due to limitations in the prison system?
Yeah.
That's open to anybody that would like to answer that.
Can I answer that first?
Absolutely.
So within our unit, this is what I always advocate with my team. We are here as nurses, and our job generally is just to advocate on behalf of any patient. So it doesn't matter who the patient is. Anyone who comes to the unit is needing our help. Our job is to advocate on behalf of them at every point. So we might have our own views, personal views about drugs and all those things. End of the day, we come to the unit to provide a service, and that service is without judgment. So we could be nursing and I have nursed in orthopedics wards where we have anyone who's a nurse would know, and anyone who's working within hospitals would know. We have the same issues in orthopedic wards: drug use, aggressive patients, abusive patients, threatening patients, no different. Patients are just patients. There's a reason why they're screaming. There's a reason why they're asking for drugs all the time. We just need to understand.
And I think, Emma, you summed this up very nicely with your, it was by saying you cannot change the world, but you can change the world of the person in front of you. And I think that's certainly something that when we've been talking with you, is that you are all committed to looking after your patients as people rather than being supporters of prisoner management. I think this is probably a good opportunity to delve a little bit into mental health. Like people on the outside, many prisoners have complex health needs, as well as a high prevalence of mental ill health. Some prisoners suffer from chronic health conditions and have histories of substance abuse, smoking, and trauma. Jo, what mental health services are available at Lotus Glen?
So you've got the Queensland Health mental health team that I said earlier that come on the Monday, Tuesday, Thursdays and Fridays. But you've also got like the psychologist and counsellors from the correctional side as well that provide, and they're there Monday to Friday as well. So
I'd like to ask Sammy. Sammy's daughter is currently a prisoner in Townsville Correctional Centre. She entered that facility with complex health needs. Sammy, how were those needs managed once your daughter was incarcerated?
Disgustingly. So my daughter, she's on a third bout of being in prison. She's got long history of domestic violence abuse, and last time she went into prison, she came out with a Suboxone habit. So she's been on the program. She also has injuries from her domestic violence, so she's in quite a lot of pain. She suffers from migraines, and she also has borderline personality disorder, ADHD, and oppositional defiance disorder, so and complex PTSD. So she knows her body and she knows what she needs. And when she went in, they cold turkeyed her off all her medications, and psychiatric medications, you can't just stop them. And for the first 2 weeks she was in there, she was so sick. And it was the corrections. I don't think it was the health staff. From memory, there was, I think, the head of the sort of, I'm not sure if it was the doctor or the nurse, came in on his day off and was just horrified at what she was going through. Because, I mean, she was withdrawing from the Lyrica she was on for her back pain. She was withdrawing from Suboxone. She was withdrawing from her migraine medication. And she, prior to going to jail, was seeing her doctor every week because the combination she was on was complex and they just disregarded everything. And then when they sort of started putting her on medication, because she does get debilitating migraines, the nurse put her on something that made her really sick, and she asked me to Google it. And I can't remember the names of the medication, but it was one that was, if you're on this one, do not take this one because it will kill you. And she trusted the nurse. It's, you know, she's had a toothache and she works, and she's got a very good work ethic, and they were short-staffed, and they packed the trolleys for the hospitals, all the towels and the blankets and everything that they have in surgery, and they were short-staffed, and it was her turn to go to the dentist, and she's like, but this won't get done. Can I go to the dentist next week because it's still okay, and I'll get this work done? Yeah, no problems. They cancelled her dental appointment, and she ended up getting such a severe infection that she couldn't eat, that prison guards were actually getting in touch with a doctor saying, she's not eating, like, you got to do something. So just, and it's heartbreaking because I hear the desperation in her voice, and there's nothing I just want to go down there and go, my child, look after her. And you just can't. I actually thought for a while there that she wouldn't come out, that she would commit suicide, that it would just get too much and she'd take her life. And I still worry about that.
And Sammy, I think the challenge also for you is, you know, the visits that, you know, visits are arranged and then they're you're not able to go in, or
I'd like $1 for every time the visits have been cancelled. I think we went 5 weeks of trying to visit her every week, and for 5 weeks I'd get the phone call, sorry, not, and it was due to not enough staff. It wasn't anything more than that.
Yeah.
I do a lot of virtual visits with her, and I'd be sitting waiting, and I'd end up ringing the prison. I'd finally get through to someone. Oh no, they were cancelled, but nobody would ring me and let me know.
Yeah.
It's very frustrating.
Yeah, a very isolating experience. Thank you for sharing that, Sammy. Yvonne, I think we've got you back online. Is there anything that you'd like to add to the conversation about, you know, your experience of mental health care within when you spent time in prison?
Mental health was a huge thing, especially like Wayne said. I was the same as Wayne. I was 50 years old. I'd never been in trouble. I did take drugs, and I got addicted and ended up in prison. And it's such a overwhelming experience to walk through those doors and know that you're not going to walk back out those doors for quite a while. And there really is no, you know, there's no sympathy, there's no empathy, there's nothing like that. It's like they strip you down, they put you in the shower, you know, next minute you're standing there naked, spreading your legs, bending over and coughing, you know, all this stuff that is like, whoa. And it really, really messes with your head. And then, you know, you go through and you get put into a cell with somebody that's, you know, maybe been there for quite a long time, or been a recurring prisoner. And they try and stand over you because you've got tobacco or you've got something that they want. And the prison officers don't give a shit. They really don't, in high security. And look, I get that their job must be so difficult, because there is a lot of rat bags in prison. But your mental health really does get affected. And what I'm going to go off course here a bit, but when I first went in, I had contact lenses, and you're not allowed contact lenses in high security in Brisbane Women's. So they gave me this shonky pair of glasses that instantly gave me headaches. I couldn't see out of them anyway. I asked, you know, when I can get to see an optometrist. They're not coming in for another 6 weeks. So I literally had a stinking headache for the first 6 weeks of being in jail. Every day I couldn't read, I couldn't fill in forms. It was mentally frustrating. They wouldn't let me have contact lenses in, weren't allowed to get them sent in, none of that. So I had to put up with literally a pair of glasses that just weren't made for me or my eyes, which, you know, damaged my eyes for 6 weeks that I had to put up with them. Luckily enough, when I got moved to the farm, I was allowed to have the contacts in. But, you know, by that time, I'd been struggling for nearly 2 months, not being able to see. You know, and it is a strain on your mental health because it gives you headaches, and then you get frustrated, and then you get angry, and then you know, it's a ball that just keeps rolling.
Yeah. Yvonne,
yeah.
At that point, I mean, you went out to the farm. That just reminded me. I mean, I went in. You go into 14 yard. I was in Capricornia, and you're in suicide watch from day one. You're in your own cell because they just want to sort of, if you haven't been to prison before, they want to make sure you're okay and you're not going to chop yourself. So the camera in your room, they see everything. And I moved over to 1 yard, which was insecure. And the standard is 3 months because I was in on remand. Yeah, I had to be in secure for 3 months. And I mean, secure unit, for someone who's never been inside a prison before, it's exactly like you see in the movies. We had a ramp up one day. They didn't find anything. I don't know how. They found a shank, like the sword. And there's 60 guys. There's all, you know, 30 cells, 2 to a cell. And that was a day I've never seen anything like it. The dogs barking behind you. You're out in the concrete on the basketball cage with your hands on your head. You march back in by 2 guards. You're told to strip down. They feel through your clothes. Your cell's being tossed. And then you're in 2 days after that because, you know, you're in cell for 24 hours for 2 days, 48 hours. We got out on the Friday for our 4 hours, and then the weekend came and they were short staffed, so you're back in your cell again.
So there's an enormous amount of fear from the other prisoners, from the unknown, that would profoundly affect your mental well-being. Lewis, I want to ask you a question, please. There are various estimates of mental ill health prevalence amongst Indigenous prisoners. So, you know, while Indigenous prisoners have lower rates of self-reported mental ill health than in non-Indigenous prisoners, there is evidence that mental ill health affects somewhere between 70 to 90% of imprisoned Indigenous people. Can you share your thoughts with us as to why that is?
Oh, I think it's very simply, it's to do with the class of society that you come from. When I saw my own GP a number of years ago, and he ran what we call a 715 health check. So it's a full full head to toe physical and mental health examination of an adult Indigenous person. And this dear friend of mine, my GP, was then asking me about family history of mental illness. Now, in my Indigenous family, there's almost no family history of mental illness. There's a huge family history of substance abuse because nobody could ever afford to go to a psychiatrist, but you can afford to buy the method down at the local hardware store and self-medicate. So I think that there's that reality that for a lot of my people, we just have not had access to sufficient mental health care to have the formal diagnoses made. and everybody assumes that that we're drinking just because we're bad, or we've got some enzyme deficiency, is the usual nonsense that gets produced as to why Aborigines can't handle alcohol. You know, no evidence of any of that. But in fact, it's this massively undiagnosed burden of mental health disorders. I was talking to people about this recently among Indigenous, they're talking about Indigenous doctors, and anybody who gets to be a senior medical officer, if you don't have PTSD, I think you're either too young, you're in denial, or you're just not working hard enough. For our Indigenous medical officers who go into this line of work, they had PTSD before they graduated primary school. And of course, most of the time we live in denial of it, because having any of those things is still has still for a long time been seen as a weakness. So we walk through life pretending that we don't have any disorders, when in fact, no, it's just stupid. We do have these problems, and we do have all these traumas in our background. The problem in Indigenous communities is that mental health has not been prioritised. And look, there's a thing of when the physical health is so terrible to start with, then the mental health is seen like icing on the cake. And if you look at just in the general community, people accessing mental health care, most people can access their GP without too much trouble. I know there's variations on the degree of trouble, but if you go to the broader Australian community and find out how easy is it to access your psychiatrist, for really rich white people, that's hard to do. For poor white people, that's hard to do. If you're poor and black at the same time, then well, that's just another level of difficulty. So I think the problem is that there hasn't been sufficient access to the to mental health services for a lot of poor people, and Indigenous people are just disproportionately in that group to actually have the formal diagnoses made in the first place. And I think the other thing is that among the more damaged ends of our society, we're a bit frightened about sending the mental health people in there, because we might have to face up to some grim realities of the country that we live in. So it's nicer for those of us living in middle class to just live in utter denial as to the burden of illness that there is. But it's awful, but it's largely undiagnosed because of a lack of access to appropriate assessment services in the first place.
Thanks.
Sorry, Lewis, can I just interrupt there? I completely agree with you, but I think it's, like I've said before, it's if you go to the nurse inside when you're incarcerated and you've got a cut on your arm, you'll get a Band-Aid. The nurse can't triage you with mental health, I don't think. And also, I mean, I'm looking at it from the outside perspective. I mean, since I've got out and I'm on bail, I'm not a poor person, I'm not a wealthy person, but access to mental health is ridiculous.
Yes, yes.
You know, and it doesn't matter which walk of life you come from these days. To get in and see someone, I think you do need to be the millionaire, billionaire, you know,
yes,
earning the $150,000, $200,000, $300,000 a year just to get an appointment.
Yes.
To maintain the appointments.
Yeah.
100% agree with you, Wayne. And for our white boys in prison, these boys are badly damaged by and large. One of the commonest consults that I have is that the boys will come in, oh doc, I can't sleep, and I'm having trouble sleeping, and they'll want us, and they want me to do a bunch of blood tests, always including their testosterone level. And I'll do all of that. And I say, that's okay, lad, we'll go ahead and do this. And when I see you in a couple of weeks, I'll give you the results, and then I'll give you my theory as to why you're not sleeping. And so a couple of weeks' time, when I'm back there, I've got all the blood results, and I can tell them their testosterone level is perfectly normal. And a lot of their other blood tests are actually looking surprisingly good. Now, son, the reason I think that you can't sleep very well is because you're stuck in a cage. You're stuck in a cage. You've had your autonomy taken from you. You don't get to make any decisions. You've got people outside that you love, and you can't talk to them, you can't hug them, you can't touch them. That everything that makes you a decent human being, you're cut off from. If I'm doing a mental health assessment on you in the outside world, one of the first things I do is a social connectedness score. And now I'm going to do a social connectedness score on somebody who's stuck in a metal cage away from everyone that they love and care about. Surprise, surprise, they're feeling a bit disconnected. You know, and the Penitentiaries Act from the very final part of the 18th century. There was a bunch of British Puritans who decided that the most important thing to happen for people inside is to spend. So the Penitentiaries Act is about being penitent, and if these guys could just have a bit more time to navel gaze as to what naughty thing they did in the first place that ended them up in prison, then that would make them a better human being. And I think that works fine for the first, couple of days, possibly up to a week and a half. But if you've got a 5-year sentence navel gazing as to what terrible thing that it is that you did all that time ago that's now continued to make your life unlivable, that's just torture. At some stage, that's just cruelty that we can't ever let somebody put past them that bad day that they had.
Yeah, I mean, I my own personal experience, I mean, I turned to drugs for trauma. I mean, I was displaced from home during the floods. I had my grandmother who raised me die. My father passed away. I was diagnosed with cancer. I self-medicated.
Yeah.
And to hide it from family, I would, purchase what I needed, plus some, on-sell it. So now I'm, like 2 counts of trafficking, got hundreds of supply charges. And, 50 years, I was a model citizen. I paid taxes. I went to work. I took a redundancy just before the floods. I can tell you the day that my crime started, and it was Easter 2019, straight after the Townsville floods.
Yep.
And, if someone had grabbed me and said, look, there's a program called NA or the STEP program, let's get you in for mental health assessments or something. But when you're on your own, there's no one to talk to or say, look, I'm really struggling. And it's the same for the guys when we're inside. My mate and I, it was our first time in prison together, and we were lucky we were celled together. The amount of nights that he'd cry, and he's a tough bloke, man who just, he did the 3-2-1 shuffle. He'd go and see the nurse in the morning because he wanted to see a psychologist because he was not mentally coping. She'd refer him to the GP, and the GP would say, no, you've got to go to the psychologist first. And he just gave up. I mean, we were lucky we made it to res in 3 weeks. We got to touch the grass and everything and have lived the good life. We're only locked in our cage for 12 hours. So, it's really hard, like from going from that position into the program, into an institution that you can't say anything, you can't do anything, and there's an unwritten prisoner code. Don't push the call button. Don't talk to that prison guard. Don't do this. Don't do that. You just do what you're told. I mean, I would run meals at night on the upstairs deck, and subbies would get flicked out, little syringes. You get told which cell to take it to. And if you didn't do it, you're a dog. And here I am, I'm inside because of drugs, and if I don't take it, I'm going to get bashed.
I think this is probably a good point at which to delve a little bit more into this issue that you've raised, Wayne, because we understand that a lot of people entering correctional centres have high rates of drug dependency. But Ash, let's start this with a question from you.
Thanks for that, Meredith. So guys, I'd like to ask, what's the deal with giving addicts drugs in prison?
Emma, I'd like to bring you in to answer that.
Sure. So I'm Emma Clough. I have been running the opioid dependent treatment program at Lotus Glen since the inception of bringing opioid dependent treatment into prisons. And that was following people keep dying. And so eventually, after many years, the government do make some changes and recommendations. if you're white anyway. So we were the pilot project amongst a couple of other sites in 2018. And so I got told what I was allowed to prescribe by the Union of Queensland Correction Services. So we used Suboxone only rather than methadone or anything else that was available. And I have got zero experience of alcohol and other drugs, other than the fact that I am Scottish and the risk of death and overdose in Scotland far outstrips most countries. In fact, it's almost as high as Aboriginal Australians are, due to, I think 5 of my brother's friends have died of heroin overdoses throughout the years. And I actually asked my brother about it the other day. I was 12 when his first friend accidentally overdosed. And so, but personally, my experience of drug use was, you know, I tried cigarettes when I was little and didn't like it. Quite an innocent person. And this idea of giving free drugs to drug addicts didn't sit well with me at all, because I'm just like, we are keeping people addicted to something that's not good for them. And then I did some homework about it, and it's like, well, actually, do you know what we have to do is we have to the only way to reach people is to meet them where they're at. And so it is impossible to speak to somebody who is in withdrawals and have a normal conversation. And it's really challenging to speak to somebody who is intoxicated and stoned and have a conversation with them. And so what giving medication to somebody who has a problem with addiction does is it allows them some stability. It allows them to not drift into withdrawals so that they can now stop and think about what they want to do. But that actually comes with a lot of problems, because the drug, the way that it works by blocking the receptor, is it actually means that if you continue to use subby, which is the only drug in prison, you also now can't get high. And so many people become addicted to medication, not because they just thought it'd be fun to give it a try, but it's actually a way of escaping their reality. And their reality is so horrendous that they inject drugs into them with aware of the risks, knowing about the risk, but their life, they need to escape it. And so I do warn people coming onto the program that I'm going to make it hard for you to escape your reality, and you are in prison and your reality sucks. But what I am going to do is I'm going to walk with you through the painful processes that you have to go through. And together we're going to come out the other side, because we are your biggest champions, because your life is not somebody in prison. You have a life on the outside. You just happen to live in this prison, but we're not planning for your life in prison. We're planning for your life back in community. And so our job is to give you some stability so you can have a think for just a brief moment to say, what am I trying to achieve here? So there are so many people who use drugs recreational and they don't have a problem with addiction. And you put those people in prison and then they get their addiction. They actually use drugs in community safely without causing harm, because they've got, Australia is quite modern. You actually have quite an amazing needle syringe programs. You literally go to every toilet that you can visit and you can put your needles in somewhere clean. You can go to many, many places and pick up some clean syringes. It's very proactive in terms of saying, look, if you want to inject drugs, please don't kill yourself whilst you're choosing to inject drugs. What you now have is the ability of, if you want to stop injecting drugs, I can help you. But it's really hard and nothing is going to be easy at all. But if I don't meet you where you're at and take you out of your withdrawals, you can't have a conversation. It's just not possible. It's ridiculous to think. And I don't know if anybody has ever experienced taking morphine-based drugs following an operation, but I talk a lot about this. I've experienced it as a patient having it. And I can tell you that the not caredness that you feel from morphine-based drugs is amazing. And certainly following my recent hip replacement, I had to choose to stop taking the pain meds. And I made that decision very consciously. It was only 5 days after my operation and I stopped taking them, because I woke up in the morning in a bit of a grumpy mood and I thought, I'll just take a painkiller. to make myself feel better. I was lying in bed, I didn't have pain, but I did not like how I was feeling. I was tired, I was grumpy, I wanted to not be on crutches. So I thought I'll just take another painkiller. And literally the last 5 years of work hit me like a bus going, it is not the person, it's people that have these problems with addiction. It's not a deliberate choice here. This is really about just being in a moment which is insufferable and trying to escape that moment. Now it's fine because we have alcohol and that is socially acceptable, but alcohol is the #1 most dangerous drug to individuals and to family. But this is a socially acceptable drug, therefore we ignore it. But picking up a pill and popping it, oh, that's not acceptable anymore because that drug happens to be illegal. That's the only reason that makes it unacceptable, is because it happens to be illegal. But who decided that it was illegal? Because actually we looked at prohibition, it didn't work. That's why alcohol is legal. If you look at countries that actually want to make a difference, things like Portugal, what do? They've stopped locking up people who have problems with drugs with criminals and giving them Hep C, Hep B, a whole host of infections that actually we haven't discovered yet, and then release them onto the streets, still struggling, and wonder why they then have this problem of coming back and coming back and coming back.
Yeah.
Emma, can I, sorry, I just wanted to make note of that Portugal Rat Park, the YouTube clip about the TED talk about addiction is absolutely brilliant. It's exactly, it's true.
We'll add that to the resource. We have a web page. We'll add that as one of the resources.
So can I make a
absolutely, Lewis.
So look, to the question, a couple of things. Google a gentleman by the name of Ethan Nadelman and listen to almost any talk that Ethan ever gives. Okay, so if we look at one of the reasons that these drugs are illegal in this country is because we're following the United States. Opiates became illegal so that men of Chinese descent didn't give them to white women and have sex with them. I think the cocaine was because I worried about Mexican men giving cocaine to white women and having sex with them. And I'm pretty sure that the marijuana was because I worried about African-American men giving it to white women and having sex with them. And that's actually the foundation of what those things were criminalized about. The comment that Wayne made about Rat Park, there's a series of studies done in the 50s and 60s looking at the evils of all of the narcotics and how they would addict various animals that we locked up in cages. And it was Bruce Alexander was the brainchild behind Rat Park. And he said, so wait a second, these monkeys that we stick in a cage and we offer them morphine or lolly water and they keep having the morphine until they die, is that because the morphine is so terrible and addictive? Or is it that actually being locked up in a cage for a social animal is so wicked that they then fall back on using these drugs to make their life better? And well, actually, that's what's going on. We really need to have another look at whether or not we need to criminalise endlessly the use of these drugs. I think it's an enormous burden to our society to have people stuck in a cage because of the sake of some medications, which fairly arbitrarily, because of a group of American Protestants, have been made illegal drugs.
Thanks.
You know, can I say something?
Yes, absolutely, Yvonne.
Yeah, you know, I don't have a problem with the drugs that are given to people in prison. What I have a problem with, a huge problem with, is why can't we have some more NA courses, AA courses? Why can't we have things like that thrown in? Because when I was in prison, I was in there for narcotics. I've never heard of NA in my life, never heard of it. It wasn't introduced to me in jail because it wasn't a program. There was no program called NA. So when I left prison, I had no idea where I was going, what I was doing. And now that I actually do the NA course at Brisbane Women's, it's amazing. It's amazing. These women look forward to it. And I would guarantee they probably look forward to it more than they look forward to taking their pills, because they're getting tools to manage on the outside. We're giving them tools. We're giving them pamphlets where they can walk out of that prison and straight into a meeting if that's what they need to do.
Connection.
I didn't know I could do all that because there wasn't the information, there wasn't the education, there was none of that when I went to prison.
Can I just add on to that? Because I've just been in this year.
Absolutely.
Courses are offered to inmates if you've been sentenced.
Yes.
So I can be sitting in there for 1, 2, 3 years on remand. I do my detox in the watch house, which I did for 5 days with 2 other guys in a 2x4 metre cell. I get transferred down to Rockhampton from my hometown of Townsville, and I'm in the watch house again because no one tells you anything. I didn't know it was lockdown day on a Wednesday. And then I'm in jail. We don't give you any education in here because you're on remand. We don't do literacy and numeracy because you're on remand. You're not a high priority. You can't get a job because you haven't done literacy and numeracy. So you can be bored and just sit and watch Days of Our Lives in your room and during lockdown. And I had my narcotics books sent up to me because I was told I could have them by the officers, and no, they had the word narcotics in them. I've never seen the books; they've just disappeared.
Yeah,
I got access to the big blue book when I made it to Res. There's 3 copies of it there. None of the prisoners knew about it, and they're either in for DV or drugs. Yet there's no resources for anyone unless you're sentenced for drug use. So we'll put you in on remand. We'll drop you off at the Caltech servo with $40 in your pocket because you now got bail. And here's a bus ticket to Brisbane. It's going to take you 13 hours. But you've got to spend 6 hours on your own across the road from where the hooker is at the local motel where you can get gear.
I think the system's not set up to rehabilitate. It's as simple as that. You know, I believe, I work as a law clerk, honestly believed in our legal system until my daughter got herself in trouble and went to jail the first time. And when she came out, you know, she's not going to pass the police check. Yet her employment agency from Centrelink would send her to jobs for it's my cockatoo. You can hear me talking. Would send her for a job as a security guard. And she's in the interview and she said, look, I'm going to be up front. I won't pass a police check. And the lady said, well, what are you doing here? Why are you wasting my time? And she said, because I have to, because Centrelink will cut my benefits off if I don't go for jobs. Yes. But they send me for jobs that I can't get. And there's no support. One example, she was on parole. We were going over to Maggie Island. She had a curfew of 9 o'clock. We were going to get home at 9:30 because of the ferry. And we spent a week trying to get a hold of her parole officer to get permission for her to be late. If she'd been kicked out of home for whatever reason and parole found out, they would have stuck her back inside, despite the fact she tried to ring them. But there was no, like, the system's broken. It's as simple as that. Yeah. They're putting people that have got medical problems into a criminal situation.
I found when during my intake there was 7 or 8 of us went in, the people that had prescribed medication to them, it would get sorted once they got down to 14 yard. The people that went Lulu and started throwing things around that didn't have medication were suddenly prescribed medication.
Well, Townsville's the opposite. You don't get anything.
Yeah.
I'd just like to step in here because
sorry.
we're just running out of time. So I'd like to end by asking all of our speakers one question, which is, what is the one thing that you'd like our future and current healthcare professionals to understand about the delivery of healthcare in correctional centres? Joe, let's start with you. What's the one thing you'd like our future and current healthcare professionals to understand about the delivery of healthcare in correctional settings?
to have an open mind, and treat people as you would be like to be treated.
Thank you. Yvonne, what would you like to say?
Yeah, absolutely an open mind, and just keep in mind that not everybody's the same. One drug addict isn't the same as the next drug addict. One alcoholic isn't the same as the next alcoholic. You know, we're individuals. Remember that. We're not just prisoners.
Thank you. Emma.
I'm trying not to steal Dr. Peachy's advice due to him teaching me an awful lot, but I can't be succinct like everybody else. I would say that it's the most frustrating job I have, and I'm trying to do it more. So I am trying to work more, even though it's very frustrating. And the reason why is because the people I work with, because there are times when we talk about somebody and with the guards, we say, oh, remember such and such, and they go, who? And I'm like, exactly. Why? Do you not know who they are? Because they left and they have not come back. And the difference that you can make when you demonstrate to people that there are healthcare workers who care desperately about you and your health and your future, they are throughout the whole system, but you will make a massive difference by being that person. And I think it's the most rewarding job of all the jobs I do.
Thanks, Emma. Wayne.
I think I would like there to be more of a focus on the rehabilitation rather than band-aiding the system, getting to the core issues of why people are there and trying to fix it before sending them out again. That'd be a good start.
Thank you. Sarouj, what are your thoughts?
I think we as healthcare workers are in a very privileged position where we must continue to advocate for these patients in front of us. We must never stop listening.
And Sam?
Listen to your patient. Quite often they know what they need. You might be the trained professional, but as someone with, I have a chronic illness as well, I know what works and what doesn't work. And, you know, I might not have a medical degree, but I know enough about my illness. And my daughter's the same. She knows what works for her and what doesn't work. And she tries to talk to the nurses, and they just, because she's a prisoner, you don't know. So listen to them. They probably know more than you do.
Thanks, Sammy. Lewis.
I'm going to be really bad, and I'm going to give a us and them comparison. So us doctors. So Dr. Claire and I, we both delivered anaesthetics in our time, and we turn up to anaesthetic audits. And in the anaesthetic audit, the thing that we have going for us is our colleagues will judge us on our better days. That if we have a bit of a mistake, if something goes a bit wrong, that we will get judged based on the reputation that they know we have for our better days. The boys in my prison, all of my boys are judged on the worst day of their life. And for the rest of their life, what follows them is the worst day of their life. And that is the gross unfairness of the incarceral system. We in the free world, we get judged on our best days. These fellow citizens that we stick in a cage are judged forever on the worst day of their life. And I think if you appreciate that, if you understand that difference, I think that goes an awful long way to help you maybe reach them, one human being to another, one heart to another.
Thank you. I think that was a very profound way to end the discussion part of tonight. Thank you. For those interested in learning more about this and other health workplace topics, our Go Rural Virtually webpage, it offers a fantastic library of session recordings and associated resources provided by guest speakers. So we'll, if you just click on the Go Rural Virtually tile, we'll add some of the resources that were mentioned tonight as so that you have access to them. And if you'd like to replay or share this episode of Go Rural Virtually, a link will be provided on the webpage in the coming days. So we started this Go Rural virtually by asking the question, where's the harm? Our hope is that you take away an appreciation of the valuable role healthcare professionals play in correctional centres, while also understanding the social, physical and emotional price prisoners pay when adherence to a system is prioritised over duty of care. I'd like to thank tonight's speakers for so generously sharing their knowledge, experience and stories with us. By providing a unique glimpse into an unfamiliar world, you opened our minds and our hearts to the power of empathy and compassion. Thank you. And a special thank you to Health Workforce Queensland team members, Wendy, Evelyn and Ash, who brought everyone together tonight.
Absolutely.
We'll be back next year with new topics, so stay tuned. Thanks everyone. Good night.